Yes, very good morning to everybody. So welcome to another session of Pediatric CME. Today, Dr. Sara is going to be presenting um, post-streptococcal glomerulonephritis. Hmm? Sorry for the delay, and over to you, Dr. Sara.
Hi, good morning, everyone. How are you? Sorry to keep you guys waiting. Okay, so the main reason I chose this topic is that I had a child who came to me about 2 weeks ago with history of passing with dark urine on and off since March 21st. He didn't have any history of trauma, any history of dysuria, but the relevant thing in the history was that he had an episode of streptococcal pharyngitis in December, which he had received 10 days of Augmentin for. So in terms of investigations, his urine was actually normal, and his renal functions were also within normal. So coming to the main issue, or the main topic of the post-streptococcal glomerulonephritis, what it is it's an immune-mediated kidney disease. Usually follows the group A beta hemolytic streptococcal infections. It usually occurs 1 to 3 weeks after pharyngitis or after a skin infection, which is what happened in this boy. And he's actually 7 years old, so it was the age is usually between 5 to 12 years of age. So it's mainly caused by the strains of Streptococcus pyogenes that affect the kidneys. It's an immune complex deposition, and it causes inflammation and reduced kidney filtration. The main presentation, like this child presented, was the hematuria, or the tea-colored or cola-colored urine. He didn't have any edema or any periorbital puffiness. His blood pressure was actually normal, so there's no hypertension in this case. And he had normal urine output. He didn't have any history of fatigue, headache, or abdominal pain, which is also one of the presentations. So investigations were as follows. The urinalysis for hematuria, proteinuria, and RBC casts. His urine white blood cells were 0 to 2. Casts were actually nil. And he didn't have any proteinuria. In terms of renal functions, they were normal. The ASO titer was 1,340. His complements were normal. Usually they present with low complement C3 levels and elevated creatinine and BUN and throat infections or cultures which are positive. And he was also positive for strep throat in December. In terms of diagnosis, the mainstay of diagnosis is the clinical presentation and the evidence of the recent streptococcal infection, which is present in both in this child. Low C3 with nephritic features are strongly supportive, but like I mentioned, his C3 was normal. And he didn't require renal biopsy, which is rarely required in cases of atypical presentation. His presentation was typical, so he didn't require a renal biopsy. In terms of management, the mainstay of management is supportive treatment, salt and fluid restrictions, diuretics in cases of edema and hypertension, which were not the case in this child, and antihypertensives, which were also not needed, and penicillin if active streptococcal infection persists. He'd already received 10 days of Augmentin in December. In terms of complications, they usually develop severe hypertension, acute kidney injury, pulmonary edema, electrolyte abnormalities, and they rarely progress to chronic kidney diseases. They usually have excellent prognosis, and they usually recover within weeks to months, sorry. And the hematuria may persist temporarily, and the renal impairment on long term is very uncommon. So the main issue is that we need to monitor their blood pressures, their urine output, renal functions, and follow up on their urine and complement levels as well. And in cases of early red flags, which are the hypertension, the edema, the abnormal kidney functions, they should be referred to a nephrologist. I had actually given the parents a referral to go see Dr. Dina, but I don't think they actually went. But as per the mom, the red colored urine had dissipated within a few days after they came to see me. So I guess that's it.
Dr. Sara, is your presentation done?
Yes, it
Oh,
was just very.
that was an ultra short presentation of 6 minutes.
I'm always very
Thank you.
short and very brief.
Thank you. Thank you. Any questions?
Just one question, Dr. Sara. So you said the PSGN usually takes place 1 to 3 weeks after infection, but this one's infection was in December, correct?
Yeah, he came to me in December actually with strep throat, and he was on Augmentin for 10 days. The mom said the symptoms of the dark urine were on and off since 21st of March, and he came to see me in April.
So would that not be like 12 weeks later instead of 1 to 2 weeks? Or 1 to
Exactly.
3 weeks?
That's what was worrying me. And I actually gave her the referral and the report to go see Dr. Dina, but I don't think they actually came to pick up the report.
Okay, so it was a very, very late presentation of PSGN.
Yes. Yeah.
But what were the findings? Was the C3 positive ASO, was anything done?
His ASO was 1,340.
What's C3, C4?
C3 and C4 were normal.
Were normal.
Yes.
So what does that say?
In the presentation, it looks like, because though it is written as low, you have mentioned as normal. That's why there's a confusion. In the presentation, I have seen it is like...
Typical is usually they're low, but he was in a normal range. He wasn't in a low range.
Oh, yeah.
And his blood pressure and renal functions were all normal. He didn't have any puffiness, so that doesn't go with nephrotic.
Both C3 and C4 were normal. Both C3 and C4 were normal.
Yeah, they were both normal.
So what does it...
With this history, Dr. Sara, we will be thinking about familial hypercalciuria or IgA nephropathy.
It is IgA nephropathy, and if both C3, C4 are normal, that's the
or hypercalciuria
difference.
But the ASO titers were very high. No?
Yes, they were.
So that points to post-streptococcal etiology.
Yeah.
That's one clue. But that C3, C4, maybe not, they're not abnormal in all 100% of cases of AGN. That needs to be looked at. So probably that is one reason why...
It's the classic differentiation. C3 and C4 are differentiating 3 different conditions. If C3 is low, it's suggestive of PSAGN because the pathogenesis is ultimately what differs. If C3 and C4 are normal, it's more tilting towards IgA nephropathy, and which is more a it is seeming like that. It's called pharyngitic nephropathy rather than post-streptococcal. And if both are high, it tends to, both are low, it tends to give a different picture. SLE would be what you should keep in differential. So that's the need to do C4 more informative in the follow-up procedure. So what you need to be doing is in IgA, persistent proteinuria is what you'll have to follow up for. Every 3 weeks, every 6 weeks, you'll have to follow up. Otherwise, if it tends to become normal, not much of a prognosticating factor for this. If proteinuria persists, there would possibly be a need to do the biopsy. Then that's when you would need a nephrologist.
Okay.
It was painless hematuria, right?
Yeah, painless.
Okay, that goes against hypercalciuria. I second to Dr. Vanita differential IgA nephropathy.
RBCs were crenated, or were there any casts? These are
no, there were no casts. No, there were no casts. RBCs were 0 to 2 and casts were nil.
Yeah, unfortunately, I don't trust our lab. They never think.
Yeah, you'll have to ask for this. Yeah, you'll have to ask for this. And you'll have to ask the percentage of crenated RBCs to normal RBCs. These are things which will give you clues for glomerular hematuria. Otherwise, it could be lower urinary tract hematuria, which would open up a wide range of differentials. And ASO very high also suggests more of symphalangitic titers. And it's acute infection, you would still find IASO.
What was the proteinuria, Dr. Sara?
His protein in urine was negative, actually.
So you'll have to follow him up for repeated assessments,
Okay.
urine for protein and BP.
Mhm.
And also the creatinine was normal, is what I
Yeah.
gather.
Yes, his creatinine was normal.
Yeah,
Yes.
that's what short presentation. I
And
happened to see the last slide only.
yeah, so the urine protein creatinine was okay. What was the range? I didn't get your answer about the proteinuria. There was an interruption here.
There were no proteins in the urine. Protein
There
was
was
negative.
no protein. There was no protein.
No.
Okay.
And family history is negative for any
No,
hematuria,
no
right?
family history of any renal diseases, no.
Because he's an adult and I'm assuming he can hear, so Albert syndrome is out of the question.
Yeah.
Okay. Thank you. That was ultra short and ultra useful. Thank you, Dr. Sar.
Thank you, Doctor.
Yeah. Thank you very much for the interaction. I think interaction was longer than the presentation for a change, or it's about the same. 6 minutes of interact. Any more questions? I think someone said they saw the last slide only. But anyway, this is put up on the YouTube, so I'll share the link. You can go back and watch the presentation. Thank you very much.
Thank you, Dr. Brahma. Thank you, Dr. Sana.
Thank you.
Thank you. Bye.